Good evening, everyone, and welcome to our webinar on hip and knee surgery. My name is Morella, and I'll be your host for this evening. Our expert presenters are consultant orthopaedic surgeons, Mr. William Dunnett and Mr. Matthew Oliver. The presentation will be followed by a Q&A session. So if you'd like to ask a question during or after the presentation, please do so via the Q&A icon, which is on the bottom of your screen. This can be done with or without giving your name. If you would like to book your consultation, Emma Chandler and Chelsea Dan will be on hand to take phone calls after the webinar, and we'll provide you with the telephone number at the end of the session. Please note the webinar is being recorded. I'll hand over to Mr. Oliver, and you'll hear from me again shortly.
Good evening, ladies and gentlemen. Welcome to the hip and knee webinar this evening. I'm going to kick off talking about hip pain and hip replacements. Next slide, please. So hip and knee surgery at our hospital. Well, we're one of the leading, if not the leading provider of hip and knee treatments in Kent and Sussex, according to the Private Healthcare Information Independent Network stats that were released in 2020. We offer treatment in an ultra clean and calm environment in a state-of-the-art hospital that has recently been renovated. The team of surgeons here are very experienced and they're established in their field, all working in the Kent and Sussex area mainly for NHS trusts. We've all trained together and practiced together for many years. Also, our very important allied health professionals that help us achieve our goals, and these are the physiotherapists here at Benenden and the expert care that the nurses and theatre nurses and scrub nurses provide, not to mention the anaesthetic team. So on the whole, we achieve very high satisfaction rates consistently, and the hospital has embraced the rapid recovery programme that many hospitals that perform joint replacements have up and running, and I'll talk to you more about that a bit later. Next slide, please. So my talk's going to have 6 main parts. I'm going to tell you about osteoarthritis of the hip, the consultation process, the treatment options that are available, and then I will brush past the surgical journey, the salient points, and talk a little bit about how one can optimize the outcome of a hip replacement. Some of that's down to you as the patient, and some of that's down to us. And then finally, I'll talk about some problems that can arise. Fortunately, they are few and far between. Next slide, please. So a little bit about myself. I've been a consultant orthopaedic surgeon now for 12 years, having started at East Kent Hospitals in 2010. I started working here in 2012, and prior to becoming a consultant, I was fortunate enough to go on an intensive adult reconstruction fellowship at the University of Calgary in Canada. I worked for 6 different professors over there that looked after the tertiary referrals for the province of Alberta. So they were serving a population of 5.5 million people. I've carried on using quite a few of the techniques that I learnt over there in my everyday practice now. In preparation for this talk, I've looked at the National Joint Registry and my figures that are in there for all to see. And I perform approximately double the national average of hip and knee replacements per year compared to my peers. And when I looked at my last NJR report, I'm fortunate enough to say, touch wood, that I've only had 4 primary hips revised in 12 years. I hope I haven't opened the floodgates now, but here we go. Next slide, please. So osteoarthritis of the hip is essentially a wear and tear condition. The joint simply wears out. It's usually of gradual offset, but can indeed be rapid in some cases. There is no specific single cause. It's normally multifactorial, but there are several risk factors that put you more at risk for developing this condition, such as being overweight and obese, because you're putting more force through the joint, having a previous injury to the hip, also being born with a congenital abnormality to the hip joint, so it hasn't formed properly and continues to develop abnormally. This is known as dysplasia. There are a few pediatric or childhood hip disorders as well that can lead to secondary osteoarthritis of the hip joint. And to date, it still remains incurable, but fortunately, it's treatable. In recent years, there's been great strides being made in joint preservation surgery for hip arthritis, helped by an explosion in interest in hip arthroscopy, stem cells, and cartilage regeneration. They haven't fixed the problem yet, so it is inevitable that the hip will continue to degenerate, unfortunately. The average age at present for both men and women to receive a hip replacement in the United Kingdom is approximately 69. The condition of arthritis of the hip is due to a failure of the fluid film lubrication of the hip joint. No artificial joint has been able to mimic this in a factory or a lab. And essentially, the pristine articular cartilage which lines the socket and the ball of the hip joint is provided nutrition by the fluid that surrounds it. This is synovial fluid made by the lining of the joint. It produces almost a friction-free environment. Unfortunately, with age, the fluid loses its zest, and other environmental factors or injuries or being obese puts the cartilage under too much stress. And as a consequence, it starts to fray and degrade, and bare bone is exposed. The patient experiences initially a little bit of pain with exertion and a bit of stiffness, but as the condition takes hold, the pain they get in the groin, which radiates into the thigh, increases in intensity. The hip starts to get stiffer because it creates extra bone spurs, or osteophytes as we call them. And they have difficulty doing everyday things such as putting on their shoes and socks, cutting their toenails, getting in and out of a car. Stride length also reduces, and they develop an uncomfortable, painful limp. Next slide, please. So when you're at that stage, the consultation with an orthopaedic surgeon is advisable, and you can come to Benenden in 3 different ways. You can self-refer yourself. You can come for a GP referral using your Benenden membership as well. And you have 20 minutes with us to basically get to know us and for us to get to know you. It's a crucial time, I personally think, because it develops a doctor-patient relationship, which is absolutely essential to get a good result if we go down the surgical journey together. In that 20 minutes, a detailed history will be taken from the patient, and quite a few of us use the Oxford Hip Score, which is a validated scoring system, which tries to grade the severity of osteoarthritis. It's out of 48 points, and it's a simple 12-question questionnaire checking out the function or lack of function that you have with everyday tasks. Lots of research has been carried out upon it, and the optimal time to have a hip replacement, or the optimal score to have a hip replacement, has been suggested to be around 26 to 30. That's the sort of range. You also have a thorough physical examination to exclude other pathologies, which I'll talk about in a minute. If you haven't had an X-ray sent to Benenden in advance of your appointment, we may send you off for one on the day. And when you return, an individualized management plan will be created for you. Next slide, please. The consultation's primary aim is to work out where the pathology is. Sometimes it is the hip, sometimes it may be the spine, or both. Sometimes it's the muscles and the tendons around the hip that hurt, or the bursa. Sometimes it's referred pain from elsewhere, and we need to make sure that we ensure that the diagnosis is correct. So the history and examination is key. Next slide, please. Special tests are sometimes required beyond the scope of a plain X-ray. If we suspect it's a spinal problem, then an MRI of the spine, which you can see directly in front of you here. There's a view of a spine, and this reveals quite severe spinal stenosis to the trained eye. This can mimic hip pain, but there are some key differentials that the history and the examination can help us work out. An MRI of the hip is sometimes useful, That can show whether you have inflammation of the bursa around the hip, known as the trochanteric bursa, or tendinopathy of the gluteus medius tendon or the hip abductor. Again, both of these conditions can mimic osteoarthritis of the hip. Occasionally, more specialized tests like an MRI hip arthrogram are required, usually in a younger patient following a sports injury. Next slide, please. So if a spinal problem is detected, then we are able to provide you, if you wish, with a cross-referral to a Benenden Hospital spinal surgeon, where you'll be seen swiftly and treated appropriately. For the other two conditions I mentioned previously, bursitis and tendinopathy, the mainstay of treatment is conservative with physiotherapy, activity modification, weight loss, analgesics, and sometimes a targeted injection into the painful area is arranged. I prefer to use the interventional radiologist here at Benenden, who will perform the injection under X-ray control. Next slide, please. Moving on now, if the hip is the primary focus of attention, if you do have osteoarthritis of the hip, there are some non-operative treatments available too, because it may not be severe enough to need a hip replacement. One thing to mention at this stage is that the hospital does have a threshold for surgery with regard to the body mass index, and that's the number 40. So weight loss would be advised to try and reduce your body mass index. Several papers have suggested in the orthopaedic literature that a high BMI is counterproductive for hip replacements, because it can lead to increased complications such as wound healing problems, infection, dislocation, and also you're putting more stress through the joint, so it may not last as long as you would wish. The non-operative management not only includes weight loss techniques, but physiotherapy and light load-bearing exercise. Both of these have had studies showing that they're beneficial to the arthritic hip, because an arthritic joint does not like to be kept still. If you keep it moving, you nourish the remaining cartilage of the synovial fluid and improve the lubrication, which diminishes the discomfort. Painkillers can also be utilized, such as non-steroidal anti-inflammatories and simple analgesics, such as paracetamol and codeine or cocodamol. Some colleagues like to also provide an intra-articular injection into the hip of local anesthetic and steroid. This is useful in my practice from a diagnostic point of view if I'm uncertain whether it's the hip or the spine causing the problem, or a bit of both. This can be carried out in theatre under X-ray control, or again an interventional radiologist can carry it out for us. Next slide, please. One thing to mention about the injection before I talk about the surgical journey: it is best advised to probably hold off hip replacement surgery for approximately 6 months following this injection, as evidence has shown there's an increased rate of infection following steroid injections to the hip if the operation is carried out too soon following it. So the surgical journey really starts with prehabilitation, and that's down to the patient to try and optimize what they have ready for a major operation. So good core stability, exercising the hip to build up the muscle strength, losing some weight, eating healthily, all helps with a swifter and a more rapid recovery. If you have decided to have a hip replacement and we've been through the informed consent process in clinic, the next stage would be to be invited up for a pre-assessment appointment, where you'll see a nurse and a consultant anaesthetist. You'll have a thorough medical, including blood tests and ECG and so on. And they will look to see if there's anything that can be optimized prior to your operation. So if you have hypertension or high blood pressure, this will need to be made better. If your diabetes is poorly controlled, then this is essential to bring back into line. Again, diabetes can complicate matters quite significantly with wound healing issues and increased infection rates. So diabetic control has to be very stringent indeed. Anemia may need to be corrected, and we'll also advise you to look after the skin on your legs so there are no breaches in the skin barrier, and also advise you to watch out for the routine infections such as a waterworks infection, coughs and colds. We need to try and eradicate all of those prior to having your operation. The rapid recovery protocol is quite well established now throughout the world, and it's a multimodal approach to help the patient through the surgical journey. It starts with prehabilitation and pre-optimization, what I've already mentioned, and then in the hospital setting, it starts with making sure you're well hydrated, well nourished, and that your analgesia is preloaded onto you before the operation starts. We'll also use low-dose spinal anesthetic to numb you from the waist down and provide injections of antibiotics and drugs to not only reduce the rate of infection, but also reduce the possibility of post-operative and intraoperative bleeding. Following the operation, a nerve root block or a nerve block may also be given to you, dependent on the anaesthetist that performs the anesthetic. This provides prolonged pain relief on the ward to help you get a good start with the post-operative physiotherapy. We try to avoid the use of opiate analgesia post-operatively, as that slows down the process, makes you feel groggy and causes other nasties like constipation. Next slide, please. So the surgical journey, you're admitted on the day. You have spinal anesthetic, and you can have sedation, so you sleep through the whole thing and not know anything until it's all over, or you can be fully awake and have a chat to the anaesthetist or listen to music. It's patient preference. After the op, you will go to the recovery suite and onto the ward, where you'll have close monitoring post-operatively by a dedicated recovery nurse and ward nurse. You'll have your own private room with en-suite facilities, and you'll usually stay for 2 nights. Sometimes a third is required, but most people go home after 2 nights. It is expected that by the end of the first day, you'll be fully weight-bearing. Once the spinal anesthetic is worn off, you'll be fully weight-bearing using a Zimmer frame. And you should receive physiotherapy twice a day whilst you're an inpatient. Next slide, please. So day 1 post-op, you'll be reviewed by the resident medical officer on the ward and your consultant surgeon. By the end of day 1, it is expected that you'll be mobile with 2 crutches, you would have practiced the stairs, and you'll be dressed in comfortable home clothes. You would have had your blood tests, and an X-ray would have been taken for us to check that the components were all appropriately seated and positioned. It is potentially possible to be discharged by physiotherapy on day 1 if you're flying, which means you can potentially go home that day, if not swiftly the following day. Next slide, please. So day 2, everybody recovers at different rates, so more physiotherapy may be required. Most patients, as I say, go home with telephone support when medically fit to do so. They're discharged with a 4-week course of oral anticoagulation. A follow-up appointment will be arranged in advance to see us again at 6 weeks. Outpatient physiotherapy will also be set up for you. If you live in the vicinity of Benenden Hospital, then you're welcome to come back to have it with the team here. If not, we will help you arrange it in your locality. And seeing a physiotherapist on a weekly basis, in my opinion, is absolutely essential to get a good result following hip or knee replacement surgery, because they make sure that you meet the milestones in the recovery passage. And again, hip precautions for the first 6 weeks, the physiotherapist will drum these into you whilst you're on the ward, and you'll be discharged with an information booklet reminding you of these. These simply mean that you don't put your hip in risky positions while the musculature around the hip joint heals. Next slide, please. When you return at 6 weeks, having had regular physiotherapy, it would be great to make sure that you're mobile with a crutch or a stick, or perhaps nothing at all. We would check the wound, and usually it would be safe to drive again. And I'm quite relaxed at this point if everything's going to plan, to discard hip precautions. So that means you don't have to sleep on your back, you can sleep on your side, and you can start to up the ante with your activities, with the aim to get back to a good quality of life within 3 months of the operation. Next slide, please. So there are a few problems that can arise, or complications that can arise from hip replacement surgery. Fortunately, they are rare. So infection, there are two types, deep and superficial. It's the deep infection that's the very worrisome one. There's a range of percentages that are quoted in the literature, depending on the surgical unit where you have your operation. The national average is about 1.5%. But in private hospitals, where it's a dedicated, clean environment, the infection rate, if all the pre-optimization has gone to plan and you're fit and healthy, the infection rate should be closer to 0.3%. So it's very unlikely. Blood clots in the leg and the lung can happen. These are known as deep vein thrombosis and pulmonary embolism, despite taking the blood thinning medication. And again, the rapid recovery protocol is essential here, because the quicker you get up and about and move after your hip replacement, the less likely it is that you'll get a blood clot in the leg. You can bruise quite heavily, as this picture here shows. This is reasonably common and is one of the unfortunate side effects of the anticoagulation medication. This doesn't necessarily mean that there is a problem, and you'll be warned in advance that your leg will go all colours of the rainbow, and sometimes you can get bruising into the buttock and up the back and down to the little toe. It'll gradually settle down. Nerve injury can be a risk, dependent mainly on surgical approach. But you can get some foot drop and some numbness in the lower leg and in the foot. Fortunately, this resolves usually over a 3 to 4 month period. It's extremely uncommon. Dislocation, that's when the ball comes out of the socket. It's down to us as surgeons to make sure that we carry out the operation competently and put the bits and pieces in you in the right place. And it's down to you not to cut corners and discard the hip precautions too soon. If we stick to good teamwork, it's extremely unlikely to happen. Leg length discrepancy. This is occasionally a headache, but we aim to try and make sure your legs are the same length, at least within a centimetre. There are various factors that make it more challenging, such as if you have a curvature of the spine, which is called a scoliosis. It can tilt your pelvis, altering the leg lengths. Also, if you've had a previous hip replacement on the other side, it can sometimes make it a little bit challenging to equalise leg lengths. Just like the human hip, implants wear out, and they usually wear out quicker than the human hip, unfortunately. And the most important thing to say here is that the longevity really is associated with the age of when you've had your hip replacement. So a patient in their 70s is unlikely to require hip revision, everything being equal, for it wearing out. Whereas a patient in their 50s probably would need to have their hip revised in their lifetime. Next slide, please. This is a useful device, this decision support tool that the National Joint Registry devised a few years ago. If you click on the link, you can put in your demographics, and they include your age, your height and weight. It will calculate your BMI. And then you go through the Oxford Hip Score questionnaire, and a chart is created for you, giving you advice as to when it thinks you should consider having a hip replacement. it'll also give you your percentage risk of revision in your lifetime at that moment in time. And you can use it as many times as you like to track your progress. So, you know, if you feel your hip is just niggling a little bit, then get your Oxford hip score and then check it again 6 months later, if you wish. So the National Joint Registry have also produced the surgeon's profile, which quite a few patients seem to be aware of now. You can look us up on there and you'll find out how many hip and knee replacements we've performed in the various places that we work. And it also tells you our 90-day mortality rates. And again, death from hip and knee replacement is extremely uncommon. So I'm not sure if that's a particularly useful bit of statistics. Then the Private Healthcare Information Network also provides information for the patient in the public domain now about our length of stay. In some hospitals are signed up to create feedback for the patient to enter into this website, so you can review some of the patient reviews of the surgeons that have had their surgery, that have provided surgery. And again, there are other review sites such as iwantgreatcare.com or .org, I think it is, and Doctify. And I know Benenden Hospital uses Doctify quite a bit for gathering reviews, not only of the organisation as a whole, but also of individual surgeons and so on. Next slide, please. I'd like to finish off with this video here of one of the success stories of hip replacement surgery here at Benenden. Please press play. Thank you.
How I was feeling before was very nervous. I've never experienced anything like this before. I don't know what I was worried about at all. I felt no pain. There was no discomfort at all, so I don't know what I was worried about. As far as I would suggest to anyone that's been offered that sort of treatment, go ahead, 100%. I was in the hospital for only the day, and I was up walking 2.5 hours after the operation. I felt as if I could run a marathon, in all fairness. I'm hoping to be out there Sunday playing golf. I'm going back to work tomorrow, so everything A-okay. Don't put it off, and as far as where you go to, you cannot beat Benenden Hospital.
I'd like to hand over now to my colleague, Mr. Dunnett, who's going to talk about knees. Thanks, Bill.
Okay. Well, good evening, everyone. It's an absolute joy to have you here with us this evening. I can safely say that presentation we've just heard from Matt was the slickest, most informative presentation I've ever heard on hip replacement ever. It took 24 minutes, and in that, I would say there is all the information I would ever want to teach a medical student or a junior surgeon to prepare their patients for hip replacement. And you'd be well advised to go through the tape that we're going to give you after this presentation and listen to it again, because it is absolutely priceless. And I would really emphasize what Matt had to say, in that establishing the doctor-patient relationship that he will do in 20 minutes is something that's fundamental to all our surgeons that work here at Benenden. We are a team, and we all understand the importance of establishing rapport and trust between us, the surgeons, the nurses, the physiotherapists, the ancillary workers, and you, the patient. And that trust and that respect is being developed from today onwards. And that's why all you people who are here listening to us this evening, you are already winners, because you want to know about your surgery. You want to know whether now is the right time for you to have a knee replacement or a hip replacement, or perhaps do you need to wait and perhaps go ahead and have a more conservative treatment to start with. Anyway, what about me? I've been a consultant in Kent for 23 years. I trained at Cambridge and Guy's. I spent a lot of my time out in Australia, where I learned about knee reconstruction. related to sports injuries, because that was my first love. But as time has gone by, I've also realized that I love doing knee replacements and hip replacements. So I do all three, in fact. So first slide, knee replacement. What is the most important aspect of knee replacement? Well, we want to give you pain relief. That's all that matters. If you have pain and it's coming from the knee, then the chances are you're going to need some form of orthopedic intervention. If, however, you have a wonky looking knee, this is called a K-shaped knee. You can see that's a nice straight knee. And the left knee of this gentleman is wonky because the articular cartilage is worn out on the outside. So it's given you a deformed knee. If that's pain-free, it's unlikely we're going to recommend replacement surgery. With this lady here, she's got what's called a varus knee, where she's lost articular cartilage on the inside. If that is pain-free, then we wouldn't dream of any major orthopedic intervention. But if, however, we've got pain in the knee, then we've got to start looking at ways of addressing that pain. So how about knee replacement? What's the commonest indication for it? Osteoarthritis. Now, if you remember Matt in his slides, he went through the causes of osteoarthritis. He said it's multifactorial. It most certainly is. It can be related to fractures, where the joint surface becomes malaligned. It can be related to ligament injuries. But actually, the biggest cause is we don't know. It is usually related to your genes. So as many good attributes that your parents or your grandparents have given you, I'm afraid to say they've probably also given you arthritis. So it is a strongly genetic predisposition. Less commonplace nowadays is doing knee replacements for inflammatory arthritis. This is usually rheumatoid type arthritis or gout related arthritis. And that's where the main problem is in the capsule of the joint. The capsule becomes thickened and inflamed, and that's what causes the pain. And that actually, while I remember, if we go back to osteoarthritis, that is primarily a problem of the bearing surface of the joint, whereas inflammatory arthritis, whether it's rheumatoid or gout, is a problem of the capsule of the joint. And we're on to a very interesting little problem that we can't satisfactorily answer. And that's why is some patients going to suffer severe pain with relatively little arthritis? And why do some get relatively mild pain for what amounts to a lot of arthritis? And the answer to that is we actually don't know in a lot of cases where the pain generator is in arthritis. Because when you lose the bearing surface in osteoarthritis, that bearing surface has no pain fibers in it. So often the patient is not aware of the arthritic change. It's only when they start getting crumbling of the bone, where you have pain fibers, they then often become aware of the arthritic symptoms. The final thing I want to mention in this slide before we move on is we're now finding that knee replacement is so successful and the results are so long lasting that we're beginning to operate on younger patients. Now, these are a special group in that we know they are going to outlive their knee replacement. So we're trying to do special methods to avoid knee replacement, or if we have to do it, then we're trying to do half or partial knee replacements, which are going to lead to easier revisions in the future. But I'll cover this a little bit later. So it's becoming an increasingly common operation, knee replacement. Back in the 60s, when hip replacements were very much to the fore, they were successful and they were giving great results. However, in the 1960s, knee replacements were not so good because we had a misunderstanding as to how the knee replacement should work. We thought it should be a nice, rigid, robust hinge, which would then give patients a durable, pain-free result. Unfortunately, that was not the case, because if you put a rigid hinge into someone's knee, it will loosen very rapidly. So we've then developed this system that has now been around in one guise or another for 30 years, which is the AGC or the Vanguard system. And what I'd like you to do is, if you look at this replacement here, you can realize what we're really doing is not replacing the knee, we are resurfacing it. This metal here is 9mm thick, and it will resurface the bearing surface, but we leave the majority of the bone of the knee intact. So that's resurfacing the femur, we resurface the tibia, and we just place this polyethylene insert in between. And you can see there's no hinge here. What we're relying on is a nicely conformed surface that allows for rotation and glide and pivoting, but it is being stabilized by the ligaments of the knee. So it is a resurfacing, it's not a replacement, and it's the skill of the surgeon by balancing the ligaments that you will get a lovely result that we hope will last for anything up to 25 years. The average age, similar to hip replacements, is quite low, at 65 to 68 in the country as a whole. In fact, in East Kent, in this area, our demographic is such that our average age of hip and knee replacement is actually a little bit older than this. And I would always tell my patients that I operate on them when they need their joint. And if they're in their late 80s or early 90s, I'm still more than happy to give them a knee replacement, because the most important thing is to give people quality of life. And if you can relieve pain and relieve unnecessary pain, I don't mind if people are at age 90, as long as they're fit and strong, they'll still get a lovely result. So this is just covering the system we use. It's made by Zimmer Biomet. The ODEP rating is 10A. What does ODEP stand for? That's the Orthopaedic Data Evaluation Panel rating. And that means that the 10-year survivorship is recorded as being 96%. And again, we go back to what Matt was saying about the NJR, the National Joint Registry. That has all this data now of every single joint replacement surgeon in the country has to have 100% of all his data recorded in this registry. So it's an extremely valuable tool. And my wife, who obviously had to overview this presentation before I gave it to you, she's a GP. She said, I have to emphasize, it's not survivorship of the patient. So in other words, you're not all going to die after you've had the knee replaced for 10 years. It's the survivorship of the components. So I do reassure you that you've got a chance of having a revision knee, and even a revision of the revision if you live to a grand old age. So I'm going to cover a little bit more about the kind of knee replacements we can offer for you, because some of them will be more stabilized than this Vanguard primary knee. So first of all, let's go into the symptoms of arthritis. And this is where we come to that important 20-minute time we have to get to know you when you're seeing the surgeon for the first time. We have to determine whether we believe your symptoms are related to primarily arthritis of the knee, or whether they're related to something else. So what about the early symptoms? Morning stiffness. Well, I'm afraid to say, as you get well into middle age, morning stiffness is very commonplace. You just have a little bit of swelling, perhaps the capsule, you haven't been using the joint for a few hours. So it's very common for people to wake up with slight stiffness. But as long as it settles within 10 minutes of use, then that's just a normal wear and tear process. We don't worry about it. If you start getting pain on demanding activity that you didn't have a few years earlier, such as going up and down multiple flights of stairs, or perhaps walking the dog for more than an hour on uneven terrain, then that might be a sign that the joint is beginning to wear. Clicking and grinding. Now, I never worry about that on its own. Lots of people have clicky joints, and there are many reasons for that. It could be you perhaps have a tendency to have a little air in the joint. Maybe your ligaments tend to abrade a little, but it's not a problem. However, if the clicking is becoming more frequent, or you're associating pain with the grinding in the joint, then that's a sign you might be getting early arthritis. And of course, swelling of a joint is a sign all is not well. There's some irritation there. So that can be a sign of early arthritis. But all these symptoms would not normally justify going ahead with knee replacement. The later symptoms are rest pain, particularly at nighttime if it wakes you up. And if the knee starts looking wonky, that's a sign things are getting pretty bad. And if your symptoms are stopping you enjoying life, stopping you walking the dog, then that is a symptom that should be regarded as being relatively high impact, and we've got to start considering doing something for you. The x-rays, a lot of store is set by x-ray, and a GP will always send you for a knee x-ray and say, well, if your x-ray is normal, you can't have arthritis. That's not quite true. Remember, a normal knee x-ray just shows the thickness of the bearing surface there and there is relatively normal, but it still doesn't mean you haven't got craters in the bearing surface like that, where things are beginning to break down. It just means the majority of the bearing surface is still intact. So an apparently normal knee joint like that still might have symptomatic arthritis. So it's critically important that you see a doctor or a surgeon who can examine you and take a history. Just as Matt was saying, it's that face-to-face examination that is very important. Don't just rely on x-rays. This is a very badly arthritic joint by comparison, but don't be fooled. That could also be an arthritic joint. So this is just an x-ray grading, and we're now 12 minutes into my presentation, so I'm not going to spend too much time on this, apart from just telling you it shows how arthritis does gradually progress by showing diminution of the articular cartilage height. So what's the treatment? It's very similar to what Matt was saying about hip replacements. Activity modification. If stairs aggravate you a lot, don't use stairs so frequently. If you've been putting on a bit of weight through COVID, not exercising very much, go on to a weight reduction regime, and you may well find a lot of your pains will improve. Physiotherapy can help arthritic pains. The reason being, the source of pain in an arthritic knee is not always coming from the joint. It might be coming from overload or imbalance of the muscles. And if you can restore balance in muscles, restore tracking of the kneecap with physiotherapy, that can relieve you of a lot of pain. Simple analgesia, paracetamols at nighttime to help you sleep, are always going to be your first line treatments. They're unlikely to lead to any long-term harm. They won't lead to any addiction. There are very few side effects from paracetamol, for instance, and I'd always favor those rather than considering any form of surgical intervention. Bracing can help in the early stages. Every patient is different as to how well they respond to braces, but the rule is avoid surgery if you possibly can. And injections, there is a role for injections for short-term relief, but not long-term management of arthritis. Now on to the surgery. Remember, I was talking about the special case for 65, the person who's under the age of 65, who's young and fit. We can sometimes realign the knee, which means we ensure that your weight-bearing axis goes through the preserved part of the knee joint and offloads the arthritic area. This can lead to good symptomatic relief for quite a few years without needing a knee replacement. But we don't tend to consider it for people 65 and over because we have better, more permanent solutions. Arthroscopic techniques, keyhole techniques can help if you have problems of loose bodies and things catching in the knee, but again, rely on the doctor-patient examination relationship to determine if that's good for you. You might hear of something called microfracture. That's where we create injury in the knee in very small areas by cracking the bone, and you have increased blood supply to that fracture, and then the body heals the fracture with a form of scar tissue that is similar to cartilage that can give you a little bit more life before you have a joint replacement. So you can see everything is aimed at delaying joint replacement until absolutely necessary. You may have heard of cartilage transplantation. We tend to use that for patients who have a small area of cartilage loss with a periphery of normal bearing surface. So it's not used for traditional arthritis. It's used for someone who has had trauma to the knee, which is a very special case. So on we go. Prior to the knee replacement, health optimization. As Matt was saying, we make sure you don't have blood pressure that isn't well controlled. We ensure your diabetes is well controlled, and weight loss is always fundamental. Now, this thing called prehabilitation, gentle physio exercises to improve muscle strength, that is important for two reasons. One, physio can help alleviate the pain of early arthritis, improve the balance of the knee, and delay surgery. But two, if you do require surgery, to establish a rapport with a physiotherapist, to learn how physiotherapy can help you, will actually improve the rate at which you recover after the surgery. So it's very much a matter of taking away the fear of the unknown by knowing what to expect after the surgery, by seeing what kind of physio you're going to get involved with. And as Matt said, on a weekly basis, it's nice to touch base with a physiotherapist, usually over the phone, mind you. Often nowadays, we don't do it as a face-to-face, but a little chat over the phone can help improve your morale enormously. And here in Benenden, we have a very thorough pre-assessment clinic. And most importantly, you'll have a discussion with the anaesthetist as well. So you can have a chat about whether or not a spinal or a general anaesthetic would be more suitable for you. So after the knee replacement, as Matt was saying, that was very beautifully presented by that patient who was ready for home on day one and said he was ready to play golf almost within a day or two. We do get you going as soon as possible after the operation, but we keep a very close eye on you. We make sure the pain management is good. Everyone's frightened of being sick after surgery. Yes, it can happen, but we have very good ways of controlling it, and it's very, very short-lived. And as Matt was saying, you can have problems of the wound healing, and certainly in the general hospital, you'd expect a 1.5% risk of infection. But here in Benenden, our risk of wound problems, infection is much lower than that, but we do keep an eye on things. Range of motion is very important in a knee replacement. In the hip replacement, we want to get you up and moving on your crutches as soon as possible. With a knee replacement, we want to get that knee bending as soon as possible, because to remember, to get out of a chair comfortably, you have to bend the knee to 105 degrees. So we will be tyrants and we will nag you and get you to bend that knee straight away. And as Matt was saying, it usually is a 2-night stay. One day in hospital is pretty amazing. We do have patients that do that, but count on 2 nights. And again, we're back to the rapid recovery protocol, which is very well established here in Benenden, and we've had some wonderful results from it. Potential risks, I'm not going to cover these because Matt's already covered them already in great detail. But you might think, oh my goodness, couldn't you tell a few white lies and not tell me about the risks? And patients do sometimes tell me that. Actually, I honestly believe it helps you with your recovery to know all the risks beforehand. And you've got to be honest. And you will recognize that here at Benenden, we have a very open approach. We are people that speak our mind, and we don't shirk our responsibility to tell the truth at all times. And you'll find you realize you trust us enormously because we're not trying to hide the facts. We're telling you everything. And so we're empowering you to really help make your own decision, because everyone's different when they're ready for joint replacements. And if we can give you all the knowledge and tell you truthfully with our eyes wide open, this is what you can expect, then you find patients are reassured, they're empowered, and they will then know how to make up their own mind when is the right time for them to have a joint replacement. So all of this can happen, but it is all rare. So I have now come up to almost 20 minutes. So I'm just going to say in these last 2 slides, really, this is an example of a half knee replacement. This is something I'm very interested in. It's one of my areas of expertise. I consider all patients for half knee replacement if they satisfy special criteria. But if they do, then I can say hand on heart, my half knee that I will give you will last just as long as a total knee, and the satisfaction you will get from it will be even higher than the total knee. It will feel more natural, it will be more supple, and it will probably, you'll recover from it a little bit quicker as well, but that's open to debate. So we will assess whether or not you're going to be a half knee or a total knee, and sometimes we use special forms of navigation rather than standard instrumentation to do the knee replacement. But again, that will depend on you, the patient. And we're now back to that all-important 20-minute relationship that we establish right at the beginning of your journey here in Benenden. So I'm not going to cover this because this is something I was going to fill in if we ran out of time. This is more just about the engineering aspects of knee replacements. I find it great fun, but I think most patients find it deadly dull. So I will leave that be. So what are the requirements of total knee replacement? Accurate restoration of the individual's mechanical axis. We want to get your knee working in an optimum way, and that happens if we restore the individual's mechanical axis by balancing the ligaments. And that is the skill of the surgeon, and nothing can replace the surgeon's skill in doing that. So we have to have accurate bone resections, and you have to do a trial reduction and make sure intraoperatively you get the right degree of flexibility. And if you have optimum placement and you have good flexibility and you plan your operation properly, that will lead to the great longevity of your implants. So that's the end of my presentation. Here is our team. And what I would emphasize, all of us are friends. We are not competitors. We rely on each other's opinion when we have difficult cases. We meet in multidisciplinary meetings. We get together and we work out solutions. When I have a difficult case, I'll actually refer you to one of my colleagues for a second opinion. And sometimes I have colleagues in London I'll refer you to as well. But we are all working together to look after you as a group. And that's what you'll notice here at Benenden. Whether it's the nurses on the ward or the physiotherapists or us lot or the resident medical officers, you'll feel as though you've actually joined a big family, and you'll think it's the most beautiful place to actually have your surgery. And in fact, you'll probably think, my goodness, I want to stay here a few more days. It's so good. But I'm telling you, tough, you can't. You have your 2 days and then you're ready for home. And that's me finished. Thank you very much.
Thank you very much. That was a really interesting presentation. We'll now take a couple of questions. So first question is, what is the difference between a total knee replacement and a partial knee replacement in terms of recovery?
Well, most people will say the recovery from a partial knee replacement is quicker. There's a study from Scandinavia and several studies from Oxford, and they have done day case surgery now, and they have found that 90% of their patients in Oxford who were selected for day case surgery have been discharged home within 23 hours. So they satisfy the criteria for day case surgery. But I must emphasize, the reason that they have been discharged within the 23 hours is usually because of the special anesthetic techniques they have to ensure they have beautiful blocks, they don't have any pain, but they have good restoration of muscle function. It's all about patient expectation, and a total knee replacement is still a wonderful option. But if you want to know the truth of it, and you want to know the literature, the recovery, both with regards to discharge from hospital and from restoration of normal function, is a little better, in that you would expect someone after a half knee replacement to be feeling pretty good at 8 weeks, whereas a total knee replacement, they'll be feeling pretty good and ready to get back to normal life at about 12 weeks. So there is a difference of 8 weeks in the recovery.
Thank you. Next question. I'm 62 and suffer from arthritis in both knees. Would you operate on both at the same time? If so, how would this affect my recovery?
Now, that's a fascinating question. If you talk to an anaesthetist, there'll be a sort of drawing in of breath, sucking between their teeth and saying, oh, I wouldn't do both knees at the same time, not a good idea. And that's a bias that has been in the orthopedic community for many years. Because if you have both done at the same time, the operation will take longer. It's more of a strain on the heart. The potential for losing blood is slightly higher, and the general insult to the body is slightly higher. But if you actually look at the literature, the risk of doing 2 separate knee replacements compared with the risk of doing simultaneous knee replacements is slightly higher if you do them with an interval apart, as long as the patient is fit and well. So that's what the literature shows. But nonetheless, the bias is that most anaesthetists will not be keen on doing bilateral knee replacements. My own personal view is that I will do 2 knee replacements at the same time for 2 distinct groups of patients. The first one is an A1 fit patient who has no morbidities at all. In other words, they don't even have blood pressure, they're not overweight, they're a perfect physical specimen. And if they are completely healthy, I will then do bilateral knee replacements, but I will ask them, why do you want to have both done at the same time? Because it's going to be quite a challenge. You're literally going to feel you don't have a good leg to stand on. And if they say, well, actually, I'm the bread earner for the family, I've got to have as little time off work as possible, so please get it done, then I will go ahead and do it. And in fact, at Benenden, I do bilateral knee replacements. And a few years ago, they produced a little video presentation and be doing a bilateral knee replacement on a patient. And he sustained a beautiful recovery. So it can be done, but you will be discouraged. Now, that's the first group of patients. In other words, someone who's very fit and well, and they need to be getting back to work. The second group is someone who has extremely severe deformities in their knees, So if you straighten one knee, you'll find the other one is so bent and deformed that actually you can't walk properly because you're just walking completely asymmetrically. And this stiffness and the bent shape of your knee will stop you straightening out the good knee that you've had replaced. So you have to do both at the same time. I would say that's fairly rare, and I probably have to do that once every 3 years.
Thank you. If you could just move on to the next slide, please, just so we can have the thank you very much. Next question. I'm 75 years old and struggle with hip pain. Is there an age limit to having a hip replacement, and would I need it done again?
There's no age limit. It's all down to personal fitness and when the time is right for the individual. You can have it done as early as in your teens, or as old as nearly 100 or 100 or more if you're fit enough. So there's no age limit. If you have a hip replacement at 75 and you're otherwise fit and well, then it is unlikely, I cannot say impossible, but unlikely that you're required to have a hip revision in your lifetime, because most hip replacements go for at least 25 years. There are things that creep up along the way, such as you could fracture the hip if you have a heavy fall later. But if you're safe on your legs and you stay well, then it should serve you well for the rest of your life.
Thank you. Next question. I'm overweight, which I feel is contributing to my severe hip pain, but I'm also struggling to lose weight through exercise because of the pain. Would you consider surgery if I'm still slightly over 40 BMI so I can be active again?
The hospital has a threshold cutoff of 40, so you have to get to 40 or below. In my practice here at Benenden Hospital, it's not all about exercise. It's multimodal weight loss. It's about looking carefully at your diet, portion control, eating the right foods, cutting out processed foods. And on top of that, with light load bearing exercises, swimming, aqua aerobics, it should be possible to bring your body mass index down. Also, there are lots of groups out there now like Slimming World, Weight Watchers, etc., that will be able to motivate you to reach your target. And it is a target that is worth reaching because it will mean that you'll recover much better when the time comes to have the operation.
Thank you very much. Next question is, why is arthritis of hip and knees accompanied by significant weakness in the legs, even though I'm still walking and taking a certain amount of exercise?
Well, because the joints are painful and invariably stiff, the hip and the knee aren't moving through the same range of motion as they once were. So the muscles around the joints do wither a little bit. But we also have to be aware that there are other conditions that could lead to weakness in your legs. You may have spinal stenosis, which is a wear and tear order of the lumbar spine that can make your legs feel quite wobbly and uncomfortable after just a short walk. And then when you take rest, the problem goes away again. So it might not necessarily just be hip and knee arthritis, but on the whole, I think it is mainly because the muscles aren't being used as they once were, so they tire easier. I don't know if you'd agree with that, Bill, or not. Do you have anything to add on that?
I wish I did, because it's open to a lot of debate. There's been a lot of research done about this, and they have found that if you do develop an arthritic joint, you do get this reflex loss of muscle mass, way more than just not exercising would suggest. So if you have someone who has unilateral arthritis of their hip, they are walking the same amount with both their legs, but you do find the musculature in the arthritic limb wastes away more quickly than the musculature in the normal limb, even though you're still walking and using it just as much. So there is a lot of debate as to why it is you lose so much muscle and so quickly. And we can't answer the question properly.
Thank you very much. One last question from Madeline. What progress on printed knees stroke hips to exactly fit the patient rather than one from off the shelf?
Oh, that's an interesting one. So 3D printing, custom-made joint replacements. There have been strides made in this. Various guises are available. You have patient-specific instrumentation which uses off-the-shelf implants. They've been around for a while now, and they make the implant more customized to the individual because they help with the position of the implant and optimize the size of the implant to fit that individual. But you can go the next step. You can actually have the implants made for you. And I think one of the brand names is called the conformist knee. I haven't had much experience of it yet, as it's not available here at Benenden or in my NHS practice. And again, it's important to add that you want a tried and tested implant which has a good survivorship. Mr. Dunnett alluded to the ODEP rating, and these more novel techniques that you've asked about are just off the drawing board, really, and haven't really got the long-term results for us to, fundamentally say, yes, I can guarantee this will last 10 years, 96.4% of the time. Would you like to add anything to that, Bill?
There's one thing I would add. I've had a little experience with a conformist knee replacement, and that is a knee replacement where the components are designed, custom made for you, the individual patient. So it's not the 3D printing, but they do design it, and they produce something that's dedicated for you, the patient. There are two problems with that. The first is you don't really know what your knee looked like before it's arthritic, because the bone has already eroded away. It's now become malaligned. So there's a bit of guesswork. You may well say, well, can't you use the other knee? Well, you can't, because the other knee may well be arthritic, but also there's often a degree of asymmetry between people's knees. So it's got to be a best guess. Now, the second thing about the conformist knee is that although you have your best guess to the design and shape of it, there's still the fundamental thing about all knee replacement is balancing of the soft tissues. As I said in my presentation, a knee replacement or a knee resurfacing is not a hinge. It is resurfacing of the bearing joint and then balancing the ligaments. And if you resurface it and you cannot balance it properly, then it will be a very poor outcome, and it will only last 6 to 7 years before it wears out. And with the conformist knee, they found that once they had manufactured these components to match the patient's physiognomy, if the computer design was poor, then you had a very difficult situation to try to restore normality in the perioperative environment. And they've created a lot of special jigs to try to overcome this problem. But then you've turned what should be a relatively straightforward operation into something that is technically very difficult. And I'm afraid to say the conformist knee run into problems with this. And so the data we've got from it has not been terribly persuasive. So I come back to, you need the skill of a surgeon who plans properly and pays a lot of attention to balancing of soft tissue. It's not about the component you put in, it's the surgeon that puts it in that matters.
Thank you very much. So our webinar has come to an end. I'm sorry if we didn't answer all your questions, but if you've provided your name, we will do so after the event. If you would like to book your consultation, please contact us on the number on your screen before. It's after 8 o'clock now, but contact us between 8 and 6 o'clock between Monday to Friday. We are offering attendees 50% off any initial appointment with the terms on the screen. You will receive a short survey, and I would be grateful if you could spare a few minutes to let me have your feedback on today's webinar. Our next webinar is on the 25th of August with consultant vascular surgeon Mr. Aaron Sweeney, who will be speaking about varicose vein treatments. So on behalf of orthopaedic surgeons Mr. William Dunnett, Mr. Matthew Oliver, myself and the team at Benenden Hospital, I'd like to say thank you very much for joining us this evening, and we look forward to you joining us again for another webinar soon. Wish you a good evening. Many thanks.